Today, I'll be discussing about how to correlate the trial records with the jaw relation records. I'm not going into the details regarding the various steps in jaw relation or during the trial procedure, nor I am restricting the topic to just complete dentures. I'll be venturing into removable partial denture also. It's because this tutorial is mainly focused on clinical tips to make a complete denture or a removable partial denture, remembering the anatomical reference points so that we will be able to fabricate a better processes that is harmonious with the patient's oral dynamics. First, let us see a complete denture patient. There are two very important lines in the frontal plane. One, the horizontal plane, and two, the vertical plane. The horizontal plane has to be parallel to the interpupillary line, while the upper maxillary occlusal rim is placed in the patient's mouth. While checking the visibility, that is, asking the patient to speak naturally and comfortably, there should be no more than 2 millimeter occlusal rim that is visible. There are exceptions. Sometimes the patient may be restricting her or his voice or lips in front of you. Or sometimes the rim may be uncomfortable or hurting to the patient to speak naturally. So the rule of thumb is make the patient relaxed. Try to start a natural and normal conversation with the patient. While she or he is speaking, try to observe the visibility, high lip line while laughing, fullness, etc. Now, check the posterior reference plane. It should be parallel to the elatragal line. This can be checked only with a Fox plane or two metallic scales or a line drawn on the elatragal reference mark and checking the parallelism with a metal scale. Now, coming to the lower occlusal rings. The lower occlusal rim should be flush with the corners of the mouth. It should not stay above or below the corners of the mouth. When the patient is naturally speaking or relaxed, this is very important. There are exceptions to this, like decreased vertical dimension, drooping of the upper lips, etc., or the height of the lower ridge. But generally, as a rule, if we try to keep the anatomical parameters within the ideal range, we can have a better prosthetic outcome. Coming to the vertical line, the one and only midline. The center of the glabella, the tip of the nose, and the tip of the chin are the main anatomical reference points. Exceptions are when the chin or nose is deviated. In such cases, if the nose is deviated, the philtrum is taken as the reference point. But most often, there may be a deviation of the nose, and we can take the chin, the philtrum, and the mid eyebrow as the reference points. Now, partially edentulous conditions. Sometimes we have to do certain modifications because of the severe deviations. That is, reduce one of the upper or lower anterior tooth to obtain an aesthetic and harmonious midline. That is to modify a lateral incisor into a canine or a canine into a lateral incisor depending upon the situation. In such patients, we find that they have a high visibility combined with class 3 arch parallelism, that is the posterior ridge may be contacting with open bite in the anteriors. In various severe cases, we have to sacrifice the occlusion for the sake of retention and aesthetics. Setting a proper occlusal scheme is the key for a successful denture, and an ideal upper anterior setting has to be followed. The relationship is more important, not the teeth placement. I mean, if there is discrepancy in the ridge when viewed from the frontal plane, the rim has to follow the relative occlusal plane as planned. That's why I said relationship is important. The horizontal plane has to be followed. In severe cases, the rim on one side has hardly any wax left while the other side has sufficient amount of wax. The non-uniformity of the ridges can be from mild, moderate to severe. While placing the waxed up occlusal rim and trying to correct the occlusal plane, most often we end up in a slanting occlusal plane, even after hours of correcting the plane with hot plate spatula. So, it is important that we ask the patient to be seated properly, head in the right position, stand back right in front of the patient, and view straight. The dental chair may be an obstruction, but try to view directly from the front. Once the horizontal reference plane is set, check the amount of ridge discrepancy. This should have been done during the diagnosis and treatment planning period, but most often we tend to skip the fine observation. Surgical correction was an option, but in cases of severe sinus drop, we need to drop the idea. In such ridge deformities, extensions, protuberances, etc., where pre-prosthetic surgery could not be planned due to various reasons, we need to modify the rim according to the patient's planned reference planes. And while articulating and setting the teeth has to be sufficiently trimmed. After the articulation is done perfectly, the anterior teeth has to be set along the outer periphery of the occlusal rim. As you know, the tip of the incisal pin should just touch the midline drawn and the occlusal rim. After the jaw relation, the size and shape of the teeth is selected according to the high lip line, low lip line, and midline marks. Rule of thumb is always do an ideal setting in all clinical situations. Remove the wax or in some case the denture base to place the central incisors. Once both the central incisors are placed, contacting the straight plane or the glass plate, go for placement of the lateral incisor 1 to 2 millimeters above the occlusal plane. Next, set the canine slightly with a mesial inclination. In the posterior plane, the buccal cusp of the first premolar should contact the straight plane or the glass plate, while the palatal cusp will remain above the glass plate. For the second premolar, both the buccal and the palatal cusp has to remain in contact with the straight plane or flat plane or the glass plate used for the purpose. The mesiopalatal cusp of the first molar should remain in contact with the flat plane, while the distopalatal cusp has to rise above 0.5 to 1 mm. From the buccal aspect, one should be able to view both the mesiopalatal and distopalatal cusps. Mesiopalatal cusp of the second molar will again rise up to about 0.5 to 1 mm above the distopalatal cusp of the first molar. This gradual rise helps to compensate the natural curves like the curve of Spee and Wilson that will be incorporated for a balanced occlusion in complete dentures. The lower anteriors should lie 1 millimeter above the occlusal plane so that a proper overjet and overbite can be obtained. It should have straight inclination and a proper arch form. Just like the inclination, the arch form is also important. Check the setting from above. If the proclination and inclination is correct, a slight amount of labral portion will be visible for all the upper and lower anterior teeth. The incisal edge will form a clear arc up to the canine teeth. From the tip of the canine, a line drawn will pass through the labial surface of all the posterior teeth except the second molar in the upper arch, which should slightly be placed palatally as shown. This will prevent the dislodgement of the distal extension of the denture and helps the denture to follow the ridge configuration. Once the lower anterior teeth is placed, remove the wax from the first molar area and place the lower first molar in proper class 1 relation. Next, you can remove the wax in between the first premolar and second premolar area and place the first premolar and the second premolar in proper intercuspation. Most often, you may have to trim the premolars to accommodate the teeth. After that, you can place the second molar in proper intercuspation and finish the process. Check the intercuspation from the buccal side as well as from the rear side of the articulator to check the lingual occlusion. Final finishing and polishing should be done and the denture is ready. Checking the trial denture of the patient's mouth, it will be taken to the laboratory for actualization and finishing. This tutorial is mainly aimed at the clinical steps to correlate between the jaw relation and the trial records in most of the complete denture cases and very special removable partial denture cases. Those topics regarding the actualization, finishing, etc. will be taken separately. Thank you.